Okay, great. Well, thank you everyone for joining us this evening for our primary care advisory group meeting. We just have one item on the agenda in addition to kind of attendance introductions, which is Pat Jones coming back to be with us again to give an update on the AHEAD model and then also talk to you all about the memo that you sent Pat a month or two ago now. So yeah, with that, I think we normally do some hybrid of attendance / introductions. And I know many of you know Pat and have known Pat much longer than I have worked at the Green Mountain Care Board. But if we want to just do a quick kind of popcorn round robin, if people don't mind saying hello, and I'll mark down attendance as we go. Valerie, I don't know if you want to kick us off, just say hi and then pick the next person to go, if that works.
Sure. I've known Pat for years. It's true. I really have appreciated her over the years. And I am no longer, as you heard, practicing, but still teaching at Dartmouth, but, you know, on my way to retirement.
See, Elliot, you're off mute if you want to say hi.
Hi, Elliot Rubin. I am a retired pediatrician, was in practice for 36 years in New Jersey, moved up here about 4 years ago, and I came home to because I went to UVM as medical school.
Hi, Pat. Tim Tanner. You know me. I'm a med peds primary care clinician at Danville Health Center now, so medical director for Northern County.
Right. I'll jump in. Faye Homan, family medicine in Wells River at FQHC Little Rivers, and have been in practice just past my 30-year mark.
Congratulations.
Congratulations, Faye. Eileen Murphy, family nurse practitioner, 25 plus years, primary care, rural Vermont primarily.
I can go next if nobody else. Okay. I'm Amelia Florence. I am a primary care physician at Gifford. I'm also their clinical coordinator for primary care and do a little bit of inpatient work as well every so often. And I've only been here for 5 years, so sorry.
No, sorry's here.
Yeah.
Go ahead, Kristen.
Would you like to clone yourself?
I'm Kristen Sheehan. I'm a nurse practitioner who do primary care in Rutland, Vermont. And I too have only been here for about 5 years. So here I am.
I think Dr. Reese.
Yeah, hi, Paul Rice. I'm family
Rice,
medicine in Williston,
sorry.
Vermont. I've been 37 years here initially with the university and then with CHP, remember them? And then the Kaiser for 2 years and then Primary Care Health Partners for 2. And now since 21 years with totally independent practice.
I've known Paul for a long time. I've known Faye, Tim. It's really nice, and Valerie, of course. It's really nice to see everybody. Thank you for letting me come back. My name is Pat Jones. I'm currently serving as interim director of healthcare reform for the Agency of Human Services. I've served in other roles in the private and public sectors for, well over 30 years in Vermont healthcare. So I worked for the home health industry, Central Vermont Home Health. I worked for Blue Cross Blue Shield, did a little bit of work at Central Vermont Medical Center, and then with the state, have been in a variety of roles since about 2000. So really happy to be here. The timing is very interesting. You know, I wanted to share with you what we know about the federal government's new model that they're apparently releasing a notice of funding opportunity by tomorrow afternoon, we think. So, you know, we should know quite a bit more when that notice of funding opportunity comes out. But we've been talking with them and looking at the material that they put out publicly. And so the picture is becoming clearer on what that new model might look like. So I thought I would start by giving you an overview of that. Welcome Robin to jump in as well, because Robin's been heavily engaged in the discussions that we've been having too. And then I had come back in the summer and you all had sent a follow-up memo with some priorities and issues. And I was hoping that we could just, have a good discussion about the issues that you raised and the priorities that you identified. So if that sounds okay, we'll go ahead and thank you. I know this is an extra meeting for you. So thank you for taking the time and in what I'm sure is a very busy week before a holiday week. So I really appreciate it. So with that, why don't we go ahead and pull up the slides. And I'll tell you that
Pat,
a lot
can I
of
cut you
the,
off for just for one
Sure.
second? I was waiting for before I pulled up the slides. We just had a phone number join, and I wasn't sure if it was another PCAG member or if it's just someone here who was joining on the phone in our attendance round robin. It looks like
it was probably me. This is Katie
yes.
Marvin.
Oh, okay, wonderful. Thank you for joining us. Okay, with that, yes, Pat, I will pull up your slides.
Yeah, so I'll tell you that the first, few slides, many of them come directly from the Center for Medicare and Medicaid Innovation, which has been designing this model. So, most of those slides are really from the horse's mouth. So next slide. Here's the agenda, as I mentioned. What I'll do with sort of the head model overview is give you a quick summary of the model, talk about the timeline as we currently know it, and then I'll dive into some key elements on the hospital global budgets component of the model. It's an important component. But I want to spend most of the time talking about the what they're calling primary care ahead, because there is a significant primary care component to the model. And then after that, I thought we could walk through your feedback from the prior meeting, and one of the questions was about opportunities for input, so spend a little bit of time on that as well. The next slide. And next. So this is CMMI's slide that they use to describe what they're calling the AHEAD model at a glance. And AHEAD stands for States Advancing All-Payer Health Equity Approaches and Development. I will not utter those words again during this presentation. It's a pretty lengthy name, but you can see that health equity is really central to the model. And so, what they're saying at this point, Vermont currently has our all-payer ACO model, and CMMI is saying that they're not going to do state-specific models anymore. Vermont has one, Pennsylvania has a rural hospital model, Maryland has their hospital global budget model. CMMI is trying to put out a model that multiple states can use. So they're trying to balance flexibility and some level of standardization across states. So the first part of the model is that similar to our current model, the state would be the signer of the agreement. If Vermont were to apply for the model, be selected, and be able to, develop an agreement that seemed like it was beneficial to Vermont. there would be these statewide accountability targets. And we have, that kind of a construct in our current model as well. And there are three main areas where the state would be held accountable. The first is total cost of care growth, and that would be measured both for Medicare fee-for-service Vermonters, not Medicare Advantage. And then it would also be measured across all payers, including Medicare Advantage, commercial payers, Medicare and Medicaid. And we currently have a total cost of care target in our model, so that's pretty familiar to us. The second, and really of importance for this group, is that CMMI is looking to see increased investment in primary care. They want measurement of, total healthcare expenditures and the proportion that is devoted to primary care. And they would like to again see that increase for Medicare fee-for-service Vermonters and also on an all-payer basis. And then third, and that's, we don't have that in our current model. So that would definitely be a new accountability. And then they also will outline equity and population health outcomes that states will be held accountable for. We have a quality framework in our current model. It's 22 measures, 3 overarching population health goals related to access to primary care, related to mental health and substance use disorder outcomes, mortality, and then chronic illness prevalence and morbidity. So we have quality measures in our current model. And but this really would want us to look at equity as well if we were to participate. And I'll note that CMMI is for the states that come on right away, and you'll see it when I show the next slide too on the timeline. But there's, it's a longer model than what we've seen in the past. Our current model started out as a 5-year model, and we've gotten an extension partly due to COVID, but CMMI is recognizing that, it takes time to make the kind of transformation that they're looking for. So this model, depending on when states implement the model, would be either 8 or 9 years. Basically, it goes through 2034. So 3 main components to the model. The first is what they call cooperative agreement funding, and that's a limited but meaningful amount of funding for states that participate in the model. They're talking about $12 million, and that would be potentially over a 6-year period. So if it was evenly dispensed, it would be $2 million a year. So it's not a ton of money, but it could help with, standing up operations, and helping to get some things in place to support model implementation. A second component is hospital global budgets, and that's for inpatient and outpatient services, and it's really a prospective payment based on prior revenues that would be adjusted for different factors over time. And then the third is primary care ahead, and that's what I'll spend most of the time talking about, is what they have in mind for primary care ahead. And then they outline 5 strategies to achieve the goals of the model. The first is to ensure that equity is integrated across the model. The second is that there be integration of mental health and substance use disorder services and treatment in primary care and in general. The third is that they are looking for what they call an all-payer approach. What that means is that initially they want to see Medicaid and Medicare at the table. And then by the second year, they want to see at least one commercial plan or payer at the table as well. And that could be a state employees plan. It could be one of the commercial insurers. It could be a Medicare Advantage plan, but they want to start to see the commercial payer involvement. Fourth, they really are focused on Medicaid alignment, both in terms of the hospital global budgets and then also the primary care ahead model, and I'll say more about that later. And then fifth, they say that they want to see acceleration of existing state innovations. And I'll say a bit more about that later as well. So next slide. This is the timeline. I also put the link to their website, and they keep adding materials to the website. And you know, there's quite a bit there, and it's pretty well done. So that's there. But in terms of the anticipated timeline, we expect the notice of funding opportunity to be published by tomorrow afternoon. They're holding a webinar tomorrow afternoon about the notice of funding opportunity, and their plan was to have that, what we call a NOFO, out before that webinar. So we shall see. As of this afternoon, it wasn't up on their big grants.gov website, but we anticipate that we'll see it within the next 24 hours. And that should have quite a bit more detail on the model and how states can apply and what they'll be looking for in the application. We think that once that is published, that there will be 100, we've heard 90 to 120 days for states to submit an application if they want to be in one of the first two cohorts. And lately we've been hearing that it will be 120 days. So that would put us into March of 2024 to develop the application. Could be as soon as February. And then the the Gantt chart there shows the timeline. They're going to limit this to 8 states, or it could be a region of a state. It doesn't necessarily have to be the whole state. And it sounds like there's some, a number of states that are interested in this. Every day I kind of hear more that there are other states that might want to jump in. So we'll see. In their materials, they sort of highlight Vermont and Maryland and Pennsylvania as the most likely candidates, but we know that there are other states that are very interested as well. So for states that would come in cohort 1, again, that February to March deadline for state applications. And then there would be an 18-month pre-implementation period that would include, negotiating the state agreement. CMS usually takes about 18 months when they're paying differently for Medicare. And then, the start date of January 1 of 2026. And then cohort 2, same time frame for submitting the application, but presumably for states that might be less ready to move forward in 2026, they would have an extended pre-implementation period that would take them to January of 2027. And then assuming that they haven't hit their 8-state limit, the third cohort, they would have a little longer to respond to the NOFO until early, January of 2025. And then a 24-month pre-implementation period that would again have them starting in 2027. So you can see there for that first cohort, 9 performance years through 2034, and then the other 2 cohorts would have 8 performance years. And I just want to emphasize, what this model does, like our current model, is it allows Medicare to be at the table in healthcare and care delivery reform, and allows them to pay differently for healthcare. So that's what, but really a key theme is that they want to see alignment across payers. So next slide. So I'll, just briefly talk about some of the key elements around this concept of hospital global budgets. So CMS will put out a methodology for calculating hospital global budgets. And what they're saying is that they're talking about prospective predetermined amounts, and it would be for inpatient and outpatient hospital services. It would be based on historical spend. They're saying that there would be annual updates for things like population changes and inflation. They do, and this really speaks to the equity, the centrality of equity, but they want to be able to adjust payments for social risk and also for quality. And they want to offer hospitals a bonus if they make improvements in health equity. They are also saying that for the first 2 performance years, for those hospitals that decide to participate, that there would be what they're calling a transformation incentive adjustment. We've been hearing in the neighborhood of 1% of their Medicare fee-for-service revenues for inpatient and outpatient services. And the idea would be that those funds could be used to support care transformation, including investments in enhanced care coordination. And then finally, they are saying that they will look at total cost of care, and that's beyond your inpatient and outpatient services. It's basically probably going to be your Medicare Part A and Part B type services. They will, for each hospital, make some adjustments based on how the hospital performs on total cost of care for those fee-for-service Medicare members, and then also for effectiveness of care, and the measure that they talk about there is avoidable utilization. So that's what we're expecting broadly in the CMS global budget methodology. In the green box there, I have a direct quote from CMS, which is that participating states with statewide rate setting or hospital global budget authority and experienced in value-based care, and I will note that that would include Vermont, can develop their own hospital global budget methodology. CMS will provide their expectations for alignment should a state decide to move forward with a state design methodology, and they will have to review and approve any state designed methodology. But that's an area where you can see there's some flexibility in the hospital global budget realm. So next slide. This is again one of their slides, and it talks about what is a hospital global budget. It's basically based on a historical baseline with these annual adjustments. But I really want to point to that third paragraph where it says that, one of the aims of this model is that they want to support hospitals in transforming care delivery and also in shifting utilization to primary care and community-based settings where it's appropriate. So that hospital global budget really does afford both reliability in revenue streams for hospitals and also flexibility. And so what CMS is looking for is for that flexibility to be used to shift that utilization and transform care. They outline a number of things that they see as incentives for hospitals to participate. I talked about the transformation incentive. I just talked about financial stability and predictability. There's some opportunity, if it's presumably not reconciled to fee for service, so there'd be the ability to share in savings. I mentioned the upside dollars for health equity improvements and potentially for quality. There's some care delivery Medicare waivers that could help in, giving some flexibility in care delivery and then potential learning opportunities. So that's what they highlight as incentives for hospitals to participate. So that's hospital global budgets. Let me actually just stop there and see if there are any questions before we move into the primary care ahead model. Okay, let's get to the good. Go ahead.
Thanks, Pat. I do have some questions about it. I don't want to take away from the talk about primary care, which we're interested in, but the part about this that indicates that hospitals would somehow be incentivized to, to support care in the community and in primary care. It really doesn't say how they would do that, does it? It sounds like they would bake in whatever been going on lately with the hospitals in terms of their budgets. And, I'm sure there's hospitals who have higher value than others in that they have, lower costs and higher quality. And there's others that don't. I don't see where this actually takes that into consideration with setting their budgets. It sort of bakes in whatever problematic hospitals already have in terms of higher budgets and inefficiency. And plus, if they're paid on these global budgets that they're sort of guaranteed, how is it that they're possibly, and you may not have the answer to this, of course, is how is it that they're possibly incentivized to move care into lower cost sites of service that obviously by definition are higher value?
Yeah, I think first of all, we, without seeing the NOFO, there may be more detail in the notice of funding opportunity. We're going to have to really look at it when it comes out. But it's also a discussion that we can have as a state. I think one of the things we've learned with the current model is that, it doesn't just organically happen that when you change payment and change the way different payers support, hospitals or healthcare, that it'll just happen. And so, there are mechanisms that we have as a state where we could more intentionally look at that kind of care transformation. And those are, should we decide to move, forward, should we get accepted? I mean, not every state is necessarily going to get accepted into the model. It would certainly be something that we would want to talk about as a state, how we can ensure that type of investment happens. So, and I will say that the primary care investment target, which I'll talk about in a moment, that certainly is a measure that the state will be evaluated on. And so the expectation is that we will see increases in primary care investment. There will be targets set if we were to participate in the model.
If I could just jump in, Pat, maybe I'll give a couple examples from the 2 other states that have global budget programs with CMS. I'll keep it short because I know we want to have time to really robustly discuss the primary care ahead model. Maryland has a potentially avoidable utilization downward adjustments to hospital payment models to provide some of that incentive. In other states, there's also performance metrics in Maryland. So the hospital has to meet certain cost and quality performance metrics for the community as a whole. So they take on the total cost of rare care risk for the community. I think the thought being that if they're not working together with the community to ensure that the quality metrics are met and that care moves to a lower cost setting, that they're going to be on the hook for a downward adjustment there. And then there's upward adjustments for quality. So that's just a couple examples from Maryland in terms of how they tried to build that in a little bit. But to Pat's point, we may have the opportunity to propose our own methodology, which could figure out if we think there are better ways to do that.
Thank you, Robin. Any other questions before we move on to primary care ahead?
I guess this is, again, more maybe in the future. How do you deal with pretty significant size hospitals that are on borders like Dartmouth, where some of our patients do utilize that, but they are Vermonters and things like that, especially if it's a state that does not become a part of this AHEADS model? I mean, I just want to make sure, that's thought about too, because for us, that's pretty significant here. And, if one state's not getting benefits or doing this, but we're expecting them to, just a thought. I know that you won't have an answer to that, but just making sure that it's addressed as well.
Yeah, it's a really important concept, and and it will enter into the total cost of care target and calculation. So it's quite important to consider that. Thank you. Okay, let's move into primary care ahead. So this again is a CMMI slide talking about really what are the goals of the primary care component of this model. The first is that, as you can see in the sentence up above the graphic, they talk about primary care really being flexible so that it can align with what state Medicaid programs are doing. I mean, in a way, with the hospital global budget, it's more sort of Medicare setting the tone, and then there is some ability for states to design their own methodology, but how can they align with that? In this case, they're really looking more to what's happening in state Medicaid programs around primary care, and how can Medicare support that. And so at least I think, that's sort of the sense that we're getting. So they outline 4 goals. The first is to increase primary care investment. So again, there will be a baseline measurement of the state's primary care investment. And the Green Mountain Care Board has done some work around that a couple to a few years ago. Really, and there's been New England in particular has really looked at this issue. Rhode Island really kind of kicked it off. And so, it'll be a calculation of the baseline amount and a target set to see increases in primary care investment for Medicare and all payers. The second goal is to align payers, and there again, you see that they're talking about bringing Medicare to the table for state-led primary care transformation, with the focus being on Medicaid alignment. The third is to support advanced primary care, and that includes mental health and substance use disorder treatment integration, care coordination, and then health-related social needs, screening, and activities within primary care. And then the fourth, and I know we have several folks from federally qualified health centers on this call, but they really want to see safety net providers in this model. And so they are looking to see, and smaller independent practices as well. So they're looking to see support for independent primary care, federally qualified health centers, and rural health clinics. And some of you may be aware of this, under the current model, we do have the comprehensive payment reform program for independent primary care. CMS is well aware of that model. We have talked to them at length about it. They are not ready to provide a capitated track for Medicare in 2026, but they seem pretty focused on doing so in 2027, and they make a note of that in this slide. So next slide. So in terms of who is eligible, it's they're seen as a voluntary program, but basically any primary care practices, including federally qualified health centers and rural health clinics that are in the state or in the region of the state, and are participating in the state's Medicaid alternative payment model, are eligible to participate in AHEAD. And in our case, we have the well-established Blueprint for Health program. They use patient-centered medical home program as an example. And so practices that are participating in the Blueprint could participate in the primary care AHEAD. For hospital-owned practices, what they've said is that they'll be eligible to participate only if their hospital is participating in the global budget component. But we directly ask the question. We have some hospitals that own rural health clinics. And so we specifically asked the question as to whether those rural health clinics could participate even if their hospital doesn't. And they came back with the answer of yes on that. So, I'm thinking of, I think, North Country Hospital, I think NVRH also owns rural health clinics. I'm sure there may be others. But in that case, even if the hospital doesn't participate, it sounds like the rural health clinic could. Next slide. So this is what CMS is saying will be the enhanced primary care payments for those practices that participate in AHEAD. And so they're saying that they will receive an average of $17 per Medicare fee-for-service beneficiary per month for those folks who are attributed to the practice. They'll pay it quarterly. There will be a small portion of the payment, of that payment, not the overall fee-for-service payment, but this enhanced payment. They're saying initially 5% and then scaling it up to 10%, that will be at risk based on quality performance. The $17 PBPM is an average. It's possible that states could earn a higher amount, up to a maximum of $21, or a lower amount, but never would it go below $15 per beneficiary per month. And so again, the requirements are that, if a practice wants to participate, it also has to be part of the Medicaid model. And again, in our case, that would be the Blueprint. And then they have to meet certain care transformation requirements, and I'll share those in a minute on the next slide. They want to see those, aligned across Medicaid and Medicare. And then how can the dollars be used? Examples they give are that it could be used to invest in infrastructure. It could also support staffing for advanced primary care, folks like care coordinators, mental health staff, community health workers, and that all should sound quite familiar to practices that participate in the Blueprint for Health, because that's what the Blueprint has tried to support as well. So next slide. These are the care transformation requirements, and we think these are examples. We'll know more when we see that notice of funding opportunity. But again, what they want to see is alignment with what is happening in Medicaid. So there's three areas that they have talked about. The first is health-related social needs. And the examples they give there is there screening for social determinants of health or health-related social needs. Are there efforts to identify and strengthen those relationships with community resources and with the organizations that actually address those social drivers of health? And then they've talked about incorporation of embedded or on-site social workers, community health workers, or other staff. And, we talked with them at some length about the Blueprint. They're aware of the Blueprint expansion work that's underway at this point. And so it feels to us like some of these elements that they've identified are very well aligned with work that we already have underway here in Vermont. And then mental health and substance use disorder treatment integration. I keep using that terminology. We tend not to use behavioral health in Vermont. We use mental health and substance use disorder treatment. There's some concern about the idea that if people change their behavior, they'll be healthy. So we tend to use the other terminology. But there, some of the examples they give are reporting on mental health and SUD quality measures. We've done some work on that in our state, as certainly in the current model, half of the quality measures are mental health and substance use disorder measures. Developing those warm handoffs to mental health and SUD providers, and managing medications for people with complex conditions. And then under care coordination, and actually this is kind of interesting because you all have a number of recommendations on engaging with specialists, but there is a focus in their examples on how to develop work streams and establish those relationships with specialty care providers, how to formalize some of those referrals, potentially through e-consults or other types of agreements, and making sure that referral systems are aligned across payers. So looking forward to hearing more about that if they put more detail in the NOFA. But that's what they're looking for in terms of care transformation. We so far feel somewhat encouraged by this because it doesn't feel like a lot of new requirements. It actually feels like work that's already underway that you all have worked very hard on, and that the state has tried to support with resources through the Blueprint for Health. So. And there's some work at the ACO, I think, and other places around, social determinants screening and such as well. So, okay, next slide. This is, I keep putting draft on this because this is, a pretty complicated slide, but, we've gotten a lot of questions about what does this mean compared to what we have in place now. And so it's our effort to show some of those funding streams in the different programs that practices either might participate in or benefit from, and to just see how that might compare to what CMS is saying they're going to offer. So that first light green set of rows is this really would be reflective of practices that are participating in the ACO. And there are two potential funding streams there. The first is for those practices that participate in the CPR program. And it's about, the last I knew, it was 19 independent practices. And so those of you who participate, I think Dr. Rice, you're definitely part of this this model. But what OneCare has tried to do is establish a target. In a way, it's like that primary care investment level, but they've established a target there. And then they calculate, they bring the different payers' payment streams together and calculate a fixed prospective payment for core primary care services to meet that target spending rate. And then in addition, for non-core services, they're offering a little bit of an above market payment for that. And then there's a $5, my understanding is that there's a $5 per member per month incentive payment as well. And I think there's also some payment for practices that are engaging in some of the more advanced mental health integration work. So, this is an effort. I can't put a dollar amount, a PMPM amount on some of this, but it's an effort to capture the CPR payments. And then for other practices, including CPR practices, there's also the population health payments that come through the ACO. There's an all-payer population health payment of $475 PMPM. But I want to note here that for Medicare, they don't pay that. They're not paying the $5 PMPM. So those payments are being covered by, presumably hospital dues and other sources of funding for the ACO. So while the payments are received for Medicare beneficiaries, they are not paid by CMS. In addition, there's a bonus payment in 2023 that's up to $1 PMPM for achieving target performance in selected measures. So that's our best understanding of what flows through the ACO. For the blueprint, there's a base patient-centered medical home payment. Medicare share of that is $2.15. Commercial's a little higher, and Medicaid is the highest. And then both commercial and Medicaid pay up to 25 cents PMPM for utilization results and for quality results. Medicare is not currently paying for that. And then finally, the community health team dollars that come through the blueprint via the ACO, again for Medicare. There's base or sort of core CHT staffing for commercial and Medicaid at $277. Medicare is a little less than that, but there's an opportunity for those risk-bearing providers in the Medicare ACO to earn more. And then I will note, you'll see in the sidebar there that Medicaid, currently also supports hub and spoke staffing for practices that provide that. Pregnancy intention initiative funding for those practices, and then most recently the enhanced community health team pilot program as well. Medicaid also provides a bit of support for SASH, the Support and Services at Home program, for some of the administrative infrastructure there. SASH, because it serves Medicare beneficiaries, is almost wholly supported by Medicare. So, that's an effort to try and compare current payment streams. Our understanding from CMS is that the $2.15 Medicare base patient-centered medical home payment that we currently get via the ACO, if we didn't have the current model, Medicare wouldn't be supporting the Blueprint or SASH. But because we have the model, that support has continued. And so the 215 would be subsumed in that average $17 PMPM. We're getting some indications that the money that currently comes through the ACO for SASH and Blueprint and CHT might still be available to us. The CMS thinks that the investment is worth it enough to continue that funding. And so we might still have the ability to support community health teams and SASH with Medicare payments. So that was a promising development. And how that all work is still unclear, but it was a very promising piece of news. Without that continued funding, it's hard to envision how SASH would continue, and it would certainly provide fewer resources for community health teams. So that, I think that might be my last. Oh no, I have one more slide, but before I move on to model governance, let me stop there. That's a lot of material. And so let me see if folks have questions around primary care head. And I just want to say outright that I'm happy to come back or, interact in any way that helps in terms of questions. Looks like Dr. Tanner.
Yeah, Pat, when you've been communicating with the CMMI folks, did they give you any hints about, CMS is really pushing the Medicare Advantage plans, maybe directly or indirectly. And so if this is only going to apply to traditional Medicare, that population is going to get less and less if they're successful in getting people shifted over to Medicare Advantage plans. Did they give any hints about making adjustments in their PMPM payments or anything about that at all?
They did not. We have raised with them the question, because we've heard this a lot from primary care and from hospitals as well, concerns about, the level of penetration of Medicare Advantage plans. What we did ask them is whether they would have any ability to require MA participation. At this point, they're saying no. Now, that doesn't mean that they can't encourage it or that down the road there might not be some ability, but it's a concern that we've heard pretty much everywhere we've gone. So, and I have not heard that they would adjust payments based on MA penetration. But it's something we should keep in mind, because if trends continue the way they have been, there is increased uptake for sure. And it's accelerated in recent years. I think Dr. Rice is next.
Thank you, Pat. It's great you outlined all of what you have on this slide here. I think it shows how complex we've grown our system, and that, I don't think any of us would have been able to come up with any explanation of what all that is. And I don't think we see patients with any of this idea in mind, that there's payments for all these little things. It's almost a lot of it is really nickel and diming, and it's just hard to understand how any of it really drives a lot of change. I think the whole concept of simplifying is great. And Medicare, I think, is onto something by wrapping it up into $17 that pretty much should cover all of this, especially in terms of the primary care, and what the primary care practices, receive per patient. The question is sort of then, how does Medicaid come up with a equal PMPM for the Medicaid population? We all know that that population is, because of a lot of social determinants of health, are very needy in that regard. Medicare patients are needy in terms of burden of disease, but how do you put a number on that? And then for how do you put a number on commercial populations? The real question comes again down to, it seems, that what we've been struggling with is we truly don't have an all-payer model, and I'm not sure why they call it that, or why we buy into that. It's a multi-payer model. Ideally, it's a multi-payer model, but we're so far from it being all-payer that that's the problem. And if it really only affects less than half of your patient population, how does it really support primary care, and how does it derive change based on the payment scheme, whatever it is, the paradigm? And so I think, don't we have to really look at, are there commercial payers, that, especially the two major ones, willing to get on board with this and be part of it? And is Medicaid really prepared to give a substantial PMPM for taking on Medicaid population patients? I don't know what there is to respond to that, but just some comments on it.
Oh, I have many thoughts. In terms of Medicaid, obviously we're subject to the state appropriations process and the limitations of the state budget. I do want to say, though, Medicaid has really tried to be at the table in as many of these payment streams as possible. For example, the 475 PMPM, I believe that Medicaid is the only payer that's paying that full amount. The commercial payers are paying, I think a good chunk of it, but my understanding is that that's subsidized. Medicare is paying nothing. So, that's one example. You see it in the base patient-centered medical home payments there as well, that Medicaid is paying the highest amount there, also paying, look, I'm not going to pretend that 50 cents PMPM for utilization and quality is life-changing, but, Medicaid and commercial are paying into that as well. And then for some of the, to get to your point about the social needs that we're seeing among Medicaid beneficiaries, I think that's why Medicaid has supported, has advocated for, with the legislature, support for the hub and spoke program for pregnancy intention, it used to be known as Women's Health Initiative, and for most recently this enhanced community health team pilot to help bring additional resources for social determinants of health, health-related social needs, and mental health and substance use disorder treatment, brief intervention type of stuff. And, so, there's definitely a recognition that Medicaid has advocated for some of these funding streams to help support the needs of Medicaid members. I think I had other thoughts too, but I talked long enough that I've forgotten. What else I was going to react to? Oh, I know. The percentage of the payers. We have limitations, as we all know, about what we can require of self-funded, employer self-funded plans. And Paul, I remember when, I talked with you when I was at the Blueprint about that, practices would get their attribution list and be like, wait a minute, I have a lot more Cigna or Blue Cross members than this, and Cigna and Blue Cross were the third-party administrator for self-funded plans. So it's a real challenge, the limitations there, and similarly with Medicare Advantage. So I hear you. We feel your pain, There's it's a concentrated, on the commercial side, it's a concentrated number of members that for which we get PMPMs on this. It's not the full range. And on Medicare Advantage, it's also not there. The support isn't there. So just wanted to affirm that basically,
Yeah, thank you, Pat. I think if this can stimulate the state to really take a more global approach to support for primary care, that's the main thing that this can catalyze, obviously, because even though there are these supports, it's not enough. We have a terrible crisis in primary care.
Yeah.
There aren't nearly enough of us and not nearly enough on the horizon. Something drastic needs to be done to support primary care base of care. And all the supports in the community are terrific and do help some, but we just don't have enough practitioners, and we've got to address that. And if this is a way to do that, then it's part of the solution.
Yeah. Did you all see the not apparently, it actually happened. The U.S. Health and Human Services Department agency, they released an issue brief last week on primary care. I don't know if folks saw that. And then there's an interesting editorial in that the Milbank Foundation put out, reacting to it, saying, I think Chris Kohler said it was like a kiss through a screen. It's like, thank you for noticing the problem. Now, what are we going to do about it, kind of thing. So if folks didn't see that, I will send it around. I'll send the link around, actually, to the Milbank editorial, and embedded in that will be the link to the HHS report. So it is obviously a national problem and of great concern. So. And Elliot, I can't remember your last name, so apologies.
That's okay. So I do have a question as to whether there's any estimate as to, sort of cost shifting, like sort of the overhead that a practice would have to increase to be able to do some of these new services, to be able to do expanded coordination of care or social determinants. Like, wouldn't you just be hiring more people? And what's the estimate of that?
Well, actually, that's one of the things, and I'd welcome your feedback on this. But that's one of the things that we actually found encouraging, because actually, Julia, if you go back to the prior slide, when we look at some of these care transformation requirements, these are things that you're already working on, and that frankly, the state is, doing it. The legislature did its level best last year to support our requests for funding, particularly in that health-related social needs circle. And so we found it encouraging. We are hoping, and again, we'll look at that notice of funding opportunity when it comes out, but we are hoping that the way that we can respond to this is we're already doing it. And so now that's not to say it's easy. We all know that not only are there workforce challenges with primary care, but trying to find social workers, community health workers, other types of staff. I mean, it is a huge challenge. but we are doing everything we can. We're doing our best to support having those staff members there to work with people with complex health and social needs. And so our hope is that this is not going to be a lot of additional work, if any, for practices, because we are pretty far along the continuum on advanced primary care here in Vermont, maybe farther than many other states, if not most other states. Maryland, has done a lot more work in the hospital global budget realm, but thanks to you all and, our legislature who has supported funding for this work, and the governor, this is work that we are quite familiar with. So that's our hope. We'll see what it looks like in the details, but my approach at this point would be to say thank you. Here are the things that we're doing. So
Thank you.
Okay, any other questions? Oh gosh, I feel like I'm just pummeling you guys at the end of a long day. But you're being very patient.
Well, the question
go ahead.
The question I had is multiple points, and it really, I'm linking off of Paul's comment about that draft slide where that's not how we see patients, and thinking about one of the comments is about potentially avoidable care. And then when you think about a lot of patients in FQHCs, CHCs, they get seen in urgent care and elsewhere, and then we're also talking about e-consults. We're talking about across different multiple institutions. So there's the hospital budget, there's the primary care budget, and who is going to benefit from that potentially avoidable care or e-consult? So if someone gets care somewhere else that was potentially avoidable, how do you track where that responsibility, accountability sits, and how much influence you have, even among institutions in Vermont, never mind the cross state border piece? So this is getting very complex.
Yeah. I'll just share a couple thoughts. I'm not going to pretend to have answers to that complexity, but when we see, there's a couple of encouraging things in this model. One is the outright payment to primary care, which is, presumably for most practices an increase over what they're getting now from Medicare. Certainly for everyone, it's more than we're getting from Medicare, but even for practices that are in multiple payment streams. There's the primary care investment target, and that has some potential to see some shifting of resources as well. In terms of accountability, I think we're going to, if we move forward with this model, we're going to want to see a pretty robust monitoring system just to make sure, to understand how resources are flowing, what's happening with the utilization, that there's appropriate, that care is occurring in the best possible setting. So, that's going to be critical to a model like this, it seems, and that will take some discussions, some, good discussion as a state as to how we want to do that. So yes, it's incredibly complicated. We definitely want to, I think there will be incentives built in to support care being delivered in the right setting. And then there's that investment that will help, the primary care investment that will hopefully help shift some resources as well. I'm not sure I answered your question, Eileen, in a great way, but other than to say there's a lot of thought going into the issues that you've raised.
Thank you.
Okay. Okay, anything else? And I'm cognizant that, oh boy, we're running out of time quickly. I just wanted to highlight for you all that one of the requirements of the model will be that there's what they're calling a model governance structure. So, anticipating that it would be a formal role, likely advisory. But I just wanted you to see what the representation is that will be required. Patients, advocacy organizations, community-based organizations, payers, and then, provider organizations, including primary care and FQHCs. And then state officials and local tribal communities. So that's a required participation in that model governance structure. And then the focus, as you'll see, is heavily on health equity. So the group will develop a statewide health equity plan, provide input on those quality and equity targets that'll be part of the state level accountability, review hospital health equity plans, and then provide input on that cooperative agreement investment funding. So I just wanted you to see that's a key element of the model. Okay, so that's all I have on ahead. We've got all of 17 minutes left. But I did want to try and talk, have a discussion on some of the feedback that you provided in September. So if we could go to the next slide. You had outlined a number of priorities for primary care, including how to incentivize transitions to value-based care, investment in primary care. And I just wanted to note that, like, on a number of these, I think there's potential for this model to address that. So certainly those first two bullets. The third bullet was interesting to me. I was involved in developing the quality framework in the current model. And in the first iteration, we had a measure about PCP visits within a year. And actually, some of our provider folks that we interacted with actually suggested that might not be appropriate for all adults. So we, turn at our request, CMS focus on adolescent well care visits. But that was a really interesting comment for me. The administrative burden, to Elliot's point earlier, hopeful that for primary care, that there won't be a lot of additional burden given what's already in place. We'll see what they're talking about in terms of quality measures. So, we'll want to keep an eye on that. I don't think it's going to be a lot of measures, but, we'll want to see what they say in terms of how the data is collected and submitted, type of thing. And there's some possibility with with a global budget type construct that we could see some. I know you all have advocated heavily on prior authorizations, and we could see some movement there with a different type of payment model. I wanted to see if you could clarify when you say lack of standardization across the ACO, NCQA, and the payers. I wanted to see if I could get a little more information on that. Are we talking about differences in prior authorization processes? Are we talking about differences in quality measures, something else, all of the above? And I don't know if anyone wants to speak to that, but.
This is Eileen, and I can speak to that a little bit since I I put the wording together based on everybody's input. This is primarily to do with all of the tracking and measures and which institution is monitoring which population health data and how are they monitoring and how are you reporting it. There's also how are you reporting on care of patients, but a lot of this is reporting data as well as the PA. And I'll let someone
Okay.
else jump in with further details.
It looks like, Paul, you have your hand up. And you're on mute.
Yes, thank you. It does include lots of different things. Prior authorization is just one of them, but they do have all sorts of different policies and formularies and which procedures or tests that they want prior authorization for. And matter of fact, I find my staff trying to get prior authorization on all sorts of tests for certain payers that don't require prior authorization because they can't. They go through the whole process. Oh, this doesn't need prior authorization. Well, some payers it does. So it's a ton of wasted time. The other is and some folks may not realize this, but they all seem to require different ways to bill for the same thing. Even in primary care offices, some want certain modifiers, others don't. They don't go by the standard Medicare billing conventions, and so we have to have all sorts of different edits in our coding and get lots of things rejected because they accept things in different ways. Blue Cross just did something recently that caused lots of us to get constant rejections that other payers don't reject, even though we're billing in the way we're supposed to. And so it goes across all sorts of things. And then there is the reporting that, United has its own program for its Medicare Advantage plans in terms of quality, MVP, and Cigna in terms of closing care gaps, want to look at different things. So it's really a jungle out there in terms of the administrative burden.
Yeah, my experience is with quality measurement, and I will tell you that I have spent a good chunk of my career trying to support alignment in quality measurement and really sort of, reasonable simplification. And I apologize for the ways in which, that I have failed in some of those endeavors, but that is one that I think we can continue to focus on potentially in this model. Is let's try, obviously, like Medicaid and Medicare have different populations, or commercial and Medicare. But, let's really work to align where we can and keep things at a reasonable level. So it's a work in progress. It's something that we have to be persistent and continue to focus on. Dr. Homan.
Well, Paul touched on this, but in terms of that lack of standardization, it's the prescription formulary, the meds. You can't get in a habit of prescribing a certain set of meds that are going to be okay with most insurances. You have no idea what's okay with anybody, and it's different between the different insurers. And we had talked before many times about either a standardized statewide formulary or, if nothing else, a list of medications from each class that everyone would cover without prior auth, so that we at least had a go-to list, like they do everywhere in the world, in foreign countries and in the military and every place. There are a list of, if you pick from this list, it's going to be fine. There won't be any problem. It's not a new concept, but if we could get our insurers to do that, it would be astounding how much time we would save. I know that Pat had asked previously about examples of problems with prior authorizations, and I have one that I didn't send out to just as an example, but the insurers are fond of telling us that it takes 36 hours and it's usually resolved within whatever they say, 10 minutes or something like that. I have one I will send out if people want to see an example that has the reference number and who we called and what we were told. But it took us about 4 months and about 9 phone calls and being on hold on a line that offered us free Walmart gift cards in order to get through to the peer-to-peer review. So prior auths and medication formulary, really important ones.
Okay, thank you. And I know it's an area that you've advocated on for a long time. And so, you know, I don't know that this model will address that, but let's keep the conversation going. And then we talked about the loss of PCPs, and I will send that link out to you so that you all have the both the issue brief. There'll be a link to the issue brief from HHS in the Milbank article. And then equitable reimbursement across provider type and site for the same care. I'm assuming that means across hospital-owned providers, FQHCs, and independent practices. Is that correct?
It was actually, there's a couple of layers more to that. If you, the first example came up for if you see an orthopedic issue in primary care and they were seeing an orthopedics for the same thing, the reimbursement would not be the same in primary care versus orthopedics. So that's just one specialty example. That's not comprehensive. And also reimbursement across physician, APRN, and PA.
Okay, thank you.
Let me jump in that we have to be careful what we ask for there, because there are actually primary care bumps that we get for being primary care. We actually get paid more for 99213s and 4s and some other things than some of the specialties because of that primary care bump. So caution.
Thank you.
Yes.
Okay, let's go to the next slide. So I needed some guidance on that first set of requests, the actionable assistance. Can someone share with, is this around sort of helping with workflows if we're transitioning from fee for service to value-based care, or is it something else?
That is what this applies to. And I would say if somebody who's going to speak to that, it'd be Faye, because we did have conversations specifically to this about getting help for that transition. It's nice to say, let's do it, but there needs to be some assistance.
Okay. Hey, do you want to add anything to that?
Well, I don't remember exactly what we talked about there, but what I'm thinking, looking at this, is us thinking about there's an awful lot of resources and programs and support that floats around that we don't know about. We need some coordination between primary care offices and entities about what supports are there. I'm always surprised when I talk to all of you guys about what you're doing in your offices, because I think, wait a minute, do we even do that? So that sort of pooling resources and making sure the information is there about them would be one thing I can think of. And Eileen, if you can think more of any others, go right ahead.
That's a great idea. I'll take that as a takeaway to sort of outline what we know about resources that are out there and really start to catalog those. Go ahead, Eileen.
I think it wasn't so much the specific steps, although we did talk about the resources. It was more just the transition from fee for service to value-based, and looking at how many things do you have to monitor and which insurances are going to require what, and how are you doing coding, all the things we already talked about, is that this still falls on the clinician. So if we are thinking there's more to it than there is and don't have the resources to put that together.
Okay, thank you. Yeah, I'll think on that and definitely try to provide some follow-up there. It looks like Dr. Rice and Dr. Tanner.
I think people are going to grow tired of my comments on this this presumption here, because I don't know what we're talking about when we say fee for service to value-based care. I really don't. If it's fee for service to capitation, then let's just call it capitation. But if it's traditional fee for service to performance-based fee for service, then I'm more comfortable with it. But I just don't understand what we're talking about here. I really don't. My take is that fee for service is value-based care if it comes with performance metrics, and so I'm not sure what we have to transition to. Higher value in a patient-centered medical home is providing all those bells and whistles that we do in a patient-centered medical home that are required under NCQA. And if we get paid for that in a different way for a management fee, then great. And that's the value being, paid for the primary care plus, if you would, the extra services. So anyway, I just feel like I have to push back against this presumption that somehow we're going to get away from fee for service, because we're really not. And the Medicare program obviously is not moving away from fee for service, just maybe traditional fee for service, which is sort of unmonitored, pay it whatever price for whatever service. Thank you.
Yeah, and I would say that, when CMS talks about value-based care, and when we think about it, we would consider fee for service with, either some additive payment for performance, or sometimes it's a withhold, but like what you see in the, blueprint currently is an additive payment for performance. And so that is, there's a continuum. It can start there. It can, certainly move toward capitation. And as I mentioned before, our expectation is that potentially for 2027 in the AHEAD model that CMS would propose a track that could include capitation. But agree with you that fee for service with performance would certainly qualify as value-based care. And Robin, thank you. Yeah, the LAN Learning and Action Network has a framework that's heavily used to talk about the different alternative payment models that incorporate value-based care, and we can send that around. It's actually a pretty elegant framework. Go ahead, Dr. Tanner.
This is sort of a continuation of Paul's comment. I mean, I think if value-based care is a global budget for primary care or capitation, there has definitely got to be a critical mass. Like, it's got to be most patients, in particular if there's risk involved. It's going to be, the practitioners are going to have most, if not all, of their patients enrolled in that kind of a program. But you just can't treat people different ways and manage risk.
Yeah. And that's going to be particularly applicable in this model for hospitals, for sure. For primary care, the only risk that we've seen so far that's been put out there is that potential adjustment to the enhanced primary care payment, which is an additive payment, a little bit of that at risk for performance. But I'm not seeing them want to put primary care at risk at this point. We are at time. I'm wondering if I could just mention a couple things. One is that, you all had asked about input and access on our website. And I just wanted to say that we've taken that to heart. And I've been working with a couple of folks that I work with to get our Agency of Human Services website updated so that, it's easier to access and more comprehensive. And so I just wanted to thank you for that and note that that's the case. And then I am going to put out there that we had been asked by Health First, by State Primary Care, and by the Vermont Medical Society if we would put together a working group on primary care, and particularly to talk about primary care ahead. And so they gave us some names of practitioners. We're trying to meet at noon times. We have an independent physician's assistant. I think most of you know Rick Dooley, who's part of that group. And then we have Toby Sadkin, who is with Primary Care Health Partners. And I'm trying to think. We have Natasha Withers, who's with Porter. She's a Porter Medical Center doctor. And we've, got the association folks are there. But if, we're trying to meet at noon times, that seems to be the most convenient. We've had a couple of meetings so far. Our next meeting is actually tomorrow. But I wanted to just, and I think we're going to continue to meet, especially now that we're going to get more information from the NOFO. And so I just wanted to offer that if you think there's someone from this group that would like to join, talk amongst yourselves, let us know, let me know if, and I know there had been a recommendation that, multiple provider types be represented, advanced practice nurses, PAs, physicians. So just wanted to offer, I don't think the group would mind. I mean, I'll mention it to them tomorrow, but I'm sure they'd be fine if you want to send somebody as a liaison to this group. So just talk amongst yourselves and let me know if that would be of interest. So. I know schedules are busy, but and at least, I think our view is the more practicing clinicians we can get, the better in that group. So, okay, I'm sorry I went over. I'm happy to come back because we didn't get through the list of your priorities. We got a good chunk of the way through, but you don't need to invite me back, but if you would like to, anytime really, to keep you informed about all this stuff. So, and thank you. Thanks for hanging in.
Yeah, thank you, Pat. In terms of your last question for PCAG, I'll send everyone an email with all of the different links we talked about. Pat, you and I can coordinate and I can package them, and I see in the chat like the land stuff. In terms of people's schedules and things, for that group, if there's folks on PCAG who are interested, if you want to just send me an email and let me know, and then I can figure out with that smaller group or with whoever has interest on if schedules align. And anyway, we can coordinate that through me is the point. So
thank you, Julia.
Yeah. And thanks everyone for taking time out of your evening. As always, I at least feel slightly better that we're not missing sunshine anymore as we sit on this call, but it still cuts into our evening. So appreciate all of your